In my last organization, I had developed a curriculum called Connecting to Purpose. It's not revolutionary. It's not brain surgery. It's literally making space. But we required it. We required attendance. So everybody from IT to marketing to food service to EVS, we taught some of the sessions in Spanish because our EVS teams were largely Spanish speaking. But it's a seminar about helping people, giving people the opportunity and helping them connect to their why. Why are you in healthcare? What does that mean to you?
My name is Jochen van der Veer. I'm the CEO and co-founder of a company called TheyDo, the journey management platform for business decision making. We raised over $50 million and are growing globally. Our enterprise customers include Ford, J&J, the Home Depot, and Pfizer. I mean, wherever you look, understanding customers is key to staying ahead. But in order to do this at scale, aligning so many different teams with the customer journey is incredibly hard, but it is possible. I really wish this podcast existed before we started our company because so many companies are organizing around journeys and there's so much to learn. So in order to share what I'm learning, what I'm hearing with our community, I meet with industry experts. And in my video podcast, I'm here to explore the world of business strategy, design, and journeys, customer journeys, to really get an understanding of how leaders are changing their way in their business. So let's dive into the show. Today, I am excited to have Joan Cox in the show. She is a Chief Experience Officer currently at LifeBridge Health. From our collaboration with organizations like the Mayo Clinic Network to her relentless focus on improving patient outcomes, she brings a wealth of insights into having a human connection in healthcare, which is a running theme if you've been listening to some of the other episodes. And it is so essential in doing good business when you are a for-profit healthcare organization, but also if you truly care about patients. So she drives transformative changes that prioritize empathy and holistic care. And Joan, it's a pleasure to have you here today.
Thank you so much. It's my absolute pleasure to be here as well.
So you have a new job or role since 3 months.
I do.
As Chief Experience Officer.
Yes.
Why don't we start there by giving a little bit of the lay of the land, what you're working on, but also what surprised you the most in your first 3 months?
Sure. Absolutely. So I've come most recently to Baltimore and to the Maryland area, to LifeBridge, from Arizona, where I was Chief Experience Officer for a healthcare system out in right on the corner of the country, on the border of California and Mexico. So it was an incredibly unique and certainly inspiring time there. So coming to Baltimore and coming back east, I'm originally from the East Coast, so it's a little bit of a homecoming in a sense. Probably what surprised me the most, it's really unique to Maryland, but it's the reimbursement structure for healthcare hospitals, healthcare systems and hospitals in Maryland. It is GBR. It's a global budget and reimbursement structure, which is very unique and very interesting in its goals and aspirations, and also interesting in its application. So that's probably the biggest challenge for me. It's not the first time I've had to make transformation from limited resources. It's certainly something that we all face in healthcare today and have for many years, especially around patient experience. But it's definitely, the stakes are high and the resources are low, quite frankly. And that's a challenge when it comes to transforming culture and optimizing the healthcare delivery process for our patients and families, especially in communities where they're disenfranchised populations and underserved and underrepresented. So, which is very much a good portion of our patient population, certainly in 3 of our hospitals and systems here. So
you mentioned culture, and
yeah.
So I'm from Amsterdam, so you have to educate me a little bit, Joan, if you
What
will.
does that mean?
Moving from Baltimore to Maryland, in the context of like a culture shift, what
Yeah.
is that like? Like, what does that mean for the different types of healthcare
Yep.
providers, or more like the service that you offer, or the people that you serve? Like, what is the difference?
It's interesting. So coming from Arizona, especially the community that I was supporting in Arizona, to Baltimore, there's honestly a lot more similarities than there were differences. Both communities are minority. Majority of the patients in the population and the patients that we serve are from the minority populations. Certainly underserved, certainly not health fluent, so to speak, healthcare fluent, I should say, not health fluent, but challenges both from, their culturally, community, resource. There's a lot of food insecurity, housing insecurity in the Baltimore area. We're dealing with a lot of violent crime. So where I was prior, not so much the violent crime issue, but more barriers to accessing care because of either historic trauma at the hands of the healthcare system or perception thereof. So when you're providing care in a very small and isolated community, so the area that I was supporting was literally in the middle of the desert. There were only healthcare system within 180 miles. So we really literally were providing care in a desert. So limited access to specialty care, limited access to recruiting and provider and service line development, but also, limited access to choices. That's definitely not the case in the Baltimore area. There's a lot of different options when it comes to healthcare choices, but we are mission driven in our relentless pursuit of improving the lives of our patients and their families and the community in general. So our investment in the community is very similar to the investment in the community that I came from the Arizona system, which is now Onvita Health. It was Yuma Regional Medical Center. But it's definitely the challenges are different, but at the center of it all are people who are vulnerable, who don't necessarily have agency to be able to advocate for themselves, and who certainly are not optimally equipped to navigate a very complicated and very challenging healthcare structure and system.
What does it mean to be mission driven today? Because there's a lot of healthcare organizations that say we're putting the patient experience first and really are trying their best, but down the line, not much happens, right? And everyone thinks they're mission driven, but where would you say, what does it mean to be mission driven today in this area?
It means to be utterly focused and embedded in the community. I guess I should take that back. It depends on what your mission is. Our mission and our slogan here at LifeBridge is care bravely. So everything that we focus on and all of the programming and outreach and work that we do is to provide the resources to our patients in the community, not just when they walk through our front door, because we know that by the time they get to us, they've already faced excessive challenges for many of them to even get to our front door. So we are taking that extra step to go out and provide the care that they need in the community. For example, we have a facility and a program called the Center for Hope, where we do just incredible, amazing work that has nothing to do with what happens necessarily in the exam room. We have a safe space for forensic interviewing for people and members of the community who are either victims of violent crime or have witnessed violent crime. So it's very much about trauma-based, trauma-informed care. We have counseling for families who've been impacted by violent crime and sex trafficking and drug trafficking and gun violence. One of our recent really focused campaigns was to disrupt the iron pipeline which is a literal, corridor of gun trafficking and gun smuggling and violence that directly and very profoundly impacts Baltimore. So it goes way beyond what happens in the exam rooms and what happens in our patient rooms in the hospitals. We know and are incredibly driven to improve and connect and collaborate with our community members.
It sounds like being in the desert for a long time with a small community is actually giving you a superpower in more like a bigger community like Baltimore is. Could you speak to me what that small community in the desert has taught you and the lessons that you're applying today?
Literally just got chills thinking about it. That small community in the desert was just utterly transformative for me from a professional perspective, but also from a personal perspective. I understood in a way that I probably had not really truly understood professionally what it means to change the lives of community members and the impact that has on multi-generations. So one of the things that I worked on when I was in Arizona was a collaboration with Indian Health Services to really break down the barriers and open up a doorway for care and access for our patients who there were two main tribes in the area who had historically had significant barriers to trusting the care that they would receive in our hospital. So we collaborated with Indian Health Services and started to build those bridges and set up programs within the hospital to identify a Native American patient when they entered. And we set up a communication line with a tribal leader to be able to notify us directly if a member of the tribe had been admitted to the hospital or was waiting in the ED or whatever the case, so that we could connect with them directly and really break down those barriers. And as a result, impacted and understanding, I understood, I think, for the first time, how changing that experience for one person can change that experience for an entire community and multiple generations. So that's profound. And that is an incredibly heavy responsibility, but what an incredible privilege. I can't even begin to say what that time meant to me. And honestly, I'd still be there. I love LifeBridge and I'm thrilled to be here and I'm grateful for the experience, but it wasn't the organization that made me leave. Really, it was all family driven. My family's on the East Coast and we had several events that took place in my family, and this opportunity came right at the same time. So I'm thrilled and privileged to be able to serve this community as well. Yuma was just a really profound moment in my life.
It sounds like a groundbreaking experience that everyone who is in patient experience should actually have, right? Being so close to it, at least that's what it sounds, being so close to the actual care and changing this community. Well, is it also true that there was much more non-digital, like hands-on work where you are actually part of this, where maybe, and I don't know, I'd love to hear your thoughts on this, but like where you're now, and the general trend in the industry is like everything is becoming digitized, AI enabled. We're going to talk about that later, but also more about the numbers, more about patients are numbers in our systems, right? I want to get them through, I want to get our money. Like, is that also a big difference for where you were and where you are now?
It is. It's fascinating because I think no matter where you are, digital engagement is part of the story, but it is not the whole story. And no matter whether you're in the middle of the desert, which really we still had certainly a significant portion of the population that it was digitally engaged. We had, huge military presence as well as snowbirds. So our population increased. It doubled, more than doubled in size during the winter because we had people coming from Canada and from northern states to winter in Arizona and winter in Yuma in particular. So we always had a fluctuation of patient populations that were comfortable or requiring a certain level of digital engagement. But the same is true here. So yes, there is certainly a focus, and the organization has a very, LifeBridge has a really focused strategy on building digital engagement. That's actually one of our big part of our strategic plan for the next 3 years. But some of our populations here have electronic insecurity. I mean, that's a thing you don't think about so much, but they may have cell phones, but they have limited minutes because they may be on a government funded plan. So they're not going to use those minutes necessarily engaging with us digitally. They're going to use it engaging with their families so no matter where you are, if you're listening to your patient population, no particular place, I don't believe in the United States, certainly in my experience, and I've worked all around the United States for the past 15 years, there certainly is no community that is homogenous to the point where one solution is appropriate. You've also got multiple generations. So you have not, and I want to disavow the assumption that the elderly population is not digitally savvy. Not true at all. Some pockets, yes, absolutely. But COVID certainly, pushed engagement on a level that we never could have anticipated. Regardless, behind all of that, human engagement and human connection is more important than ever. And there will never be a time that digital connection will replace or fill the need for someone to make contact and be seen and heard and communicated and understood by another human being. That power is immeasurable and certainly a critical piece of the healing journey.
How should we think about digital engagement then, in a way where we make trade-offs decisions in when digital is the first way we connect with our patients versus like maybe in person or an actual human being reaching out or having that conversation is appropriate? Like, do you have a framework or do you have a way to think through like how to make these decisions across any patient journey or experience?
Yeah. So unfortunately, my process is always that our digital engagement should be a supplement. It should be supporting and supplementing the human engagement and that human interaction. It should be supportive instead of replacing. And unfortunately, oftentimes digital solutions are sought out to replace human capital. And it's seen as a cost reduction opportunity. Never seen that happen in a fully functional and beneficial way. Financially, possibly, but you end up paying for it on the other end, whether it's your HCAHPS or your CGCAHPS performance. Patient experience surveys are directly tied to many of our reimbursement contracts in the United States in particular, and a huge piece of our reimbursement. So disengaging is not the way to save money. It's just not. And unpopular opinion, I know, and I'm sure that there are plenty of vendors who would not be happy to hear me say that, but there's no question. Even the younger generation, even the digital generations, when they're sick, they want somebody to talk to them. They don't want to schedule the appointment with a person necessarily, but they don't want to be assessed by someone, by something. They want to be assessed by someone. They want to be treated by someone. But there are absolutely elements of access to care and facilitating care that can be digitized and should, quite frankly, be digitized just for accuracy, convenience, opportunity, opening schedules, things like that. But that again, that's to facilitate that emotional and that human connection. It's not to replace it.
Right.
Or it shouldn't be.
If you're enjoying this conversation, don't forget to subscribe on your favorite podcast channel and leave a review. It makes all the difference. The Experience Edge podcast is where I interview business leaders, CX pioneers, and the best designers who share their insight on creating business impact, having an edge on the customer experience. Do you want more exclusive content and behind-the-scenes access? Check out the Experience Edge podcast on YouTube and LinkedIn so you don't miss a thing. Now let's get back to the conversation. I want to double click on what you said earlier, like the way you measure this. You said surveys are tied to our reimbursement, or our survey programs are tied to reimbursement, if I got that right. That's one way of doing it, and maybe like we should unpack that. And I'm also curious, like what are other ways where you can prove the inverse is true, right? Where digital not necessarily leads to better care and lesser care leads to missed opportunity in terms of revenue or growth, or however you want to put it. Like, can you unpack those two? So the survey piece, and then also other ways that you can actually prove the case is true?
Yeah, absolutely. So the survey piece, there are many different reimbursement structures throughout the United States, and there's different hospital, there's value-based purchasing. On the inpatient side, there's value-based care on the med practice side. And then there's GBR, which is the Maryland structure. But regardless of what reimbursement program or contract you're engaged in, even commercial contracts have a patient experience quality metric that you have to meet in order to get your full reimbursement potential from that contract. So that is the way that is measured is through either the HCAHPS, which are the hospital compare scores, or the CGCAHPS, which are the med practice or group scores. So those surveys are sent out directly to patients, and how patients respond and grade the experience according to those surveys directly are directly fed into through CMS, Center for Medicare and Medicaid Services, and then directly to our reimbursement structure. So whether it's, and depending on the contract, it can be 40% of your quality score is patient experience, depending on what contract you're in. We're talking, that's been the progression. And when you see patient experience so highlighted now and such a central focus, I would love to think that it's because everyone is finally understanding how absolutely essential it is. It's largely because reimbursement is directly tied to it in a way that it has not. I mean, because it increases year over year. So millions and millions and millions and millions of dollars per organization is based on patient experience performance in one way or another. I don't know that there are many organizations out there that are able to get away with not relying on patient experience performance. And even if it isn't directly tied to the contract, which most of them are, it's directly tied to your digital profile and your footprint on the internet. And that's the first, your digital front door is how you present as an organization, a facility, as a physician on the internet when a patient goes to search for a potential care provider. So your starred ratings, your Google rating, your hospital compare reports, all of the different public profile and public facing performance is part of that decision-making process for a patient. So you can't get away from it. It's there, but there's a lot of money tied to it.
Isn't it also ready then to be gamed, right? That we are cranking up the survey responses from patients, and there's a lot of scrutiny around that because, again, we're asking them to fill in that survey after the care. Sometimes they really don't want to do that.
So there's actually, when it comes to the HCAHPS perspective, the HCAHPS and the CGCAHPS, the surveys that are regulated by CMS, we can't touch them. There's actually very specific ways that we can and cannot talk about them to patients. It's not as easy to game it as you would think it would be. It's not like going to, get you buy a car and they say, hey, give me a good, make sure to give me a good score. Trust me, plenty of people would like to see that happen. And there are strategies that organizations look for. But ultimately, it's a random sampling. It's a weighted, it's a black box weighting. So we don't even necessarily know fully how it's all calculated. It's not as easy to game the system as you would think.
Only by providing really good care, you will game the system. That's basically how it works.
Absolutely. Yeah. And you know what? Quite frankly, if you're an organization that's looking to game the system, you might want to consider a different industry because it's all about making it a better experience for the patient to improve clinical outcomes. And to your point, what are some of the, your other question earlier, what's some of the proof that this really does have a significant impact? We know the data shows, we know that organizations with high patient experience scores have better clinical outcomes. The reason for that is that patients are engaged in their care in a way and on a level that doesn't happen when it's not relationship based. If someone feels as if a patient does not feel connected and does not feel seen, heard, or known by the person, or even has not had hands laid on them, you'd be surprised how many patients say to me, they didn't even touch me. And no, they looked at your lab results, but people want to be cared for physically, emotionally. And they're not looking for a therapy session every time they walk in to see their physician. They're literally looking for a moment of human connection and to be reassured and know that the person caring for them knows them on some level because they've looked at their notes, they've looked at their labs, they've looked at them, or they've asked them some questions. It's frightening how simple it is, but it's also frightening how hard it is for us to figure out how to make this impact one that resonates with the patient.
Yeah, no, and the reason I asked is that in commercial organizations so customer experience is often gamified because bonus payments and on target earnings are tied to NPS, and it just makes sense to game the way we ask. Even like color coding the results is something that people sometimes do to just hack a little bit towards the green and then make sure that that NPS jumps a little bit. And what I hear you say is actually what makes the biggest difference between, I think, healthcare and commercial organizations. It is actually about experience as a medicine. I had let me see in my notes. I had Richard Swartz on the podcast the last time, and he said the same. Right? It is a medicine. Experience is a medicine, but in commercial organizations, we're often seeing it as a cost center, right? It's like something to be gamed or something to add. But in healthcare, that's the other way. So how are you organized? Like, how are you organizing your teams? And maybe we should start with the mission of your role, right? You're the CXO. You're at the top. But how is your team constructed? And how are you thinking or acting on organizing around the patient?
Yeah, great question. So my role is new. It was new at Onvita, and it's new here as well. So both organizations, first CXO to join the group. Here I have multiple facilities. So there's multiple hospitals, and in each hospital, there is a local central manager of patient experience who fields the advocacy, which is, whether it's patient complaints and grievances or coaching. So being able to go out onto the units and coach and support. And they are team members underneath that manager who they have various roles. Concierge, we have concierge roles where we have people who float and are dedicated to different units, a lot of work being done in our EDs with concierge, just literally someone there to check and round on patients to make sure from a non-clinical perspective that they're comfortable, that they have, a blanket or a pillow, or we have a, comfort cart that we send around. And really it's about literally having people making connections with patients throughout their journey. And especially in the ED, we know many things about EDs, but you don't end up in the ED because you planned to be there. It's unexpected. It's disruptive. It's fearful. Your acuity is to the point where you couldn't wait to be seen in an office. Oftentimes, sometimes it's because you don't have any other access to healthcare other than going to the ED. But oftentimes the patients are, they're sicker, they're scared, they're not expecting it. There's going to be disruption to their personal life, whether it's, who's going to be at home watching the kids, whether they're going to miss work. So there's a lot of anxiety around ED experiences, but we also know that ED admissions produce lower HCAHPS, lower patient survey outcomes. So our scores are lower in the population that's admitted directly from the ED. So that's a real significant focus, is making sure that we're meeting patients where they are and providing them that kind of comfort level and that anxiety reduction at the point of the ED admissions. But that carries through to the inpatient units as well. So I have teams that consist of analytics, consist of concierge rounding, coaching. So that's someone who is rounding on the units, but also providing best practice recommendations and training and sharing action plans and items, et cetera. So I work closely in my role as well with marketing, with IT. So really the whole the purpose of a CXO is to be able to have that seat at the table with the rest of the executive team so that the patient experience is represented at the same level that IT is and that finance is and that marketing and chief, and medicine. And so that it's part of the decision-making process. And it's being able to have someone there asking the question. And you'd be amazed at how often people who have the best intentions and really, truly want to do nothing but improve care for our patients and their families, because they're so focused on their own individual service line or focus in the organization, lose sight of the impact that the decisions that are being made have on the patient. So it's having that patient voice at the table really is, and it is a game changer. It certainly is a game changer.
When you think about your peers in IT or analytics, or actually like in medicine themselves, the doctors, like how do you think about aligning them on, let's say, a single patient journey? Because I can imagine the people in the hospitals are doing tremendous work day to day, fixing, helping, executing their job, doing their job, and doing a little bit beyond that. So when things happen, they are able to, fix the escalation. But how do you approach the systemic issues and get them on the table and work with people? Like, have you done a lot of work on getting them also to own part of the patient journey, or is that something that you're setting up? Like, can you talk to me about where you are with that?
Absolutely. Yeah, absolutely. Compassion fatigue is real. And it is a real challenge from a clinical perspective.
Sorry, from a physician fatigue?
Compassion fatigue.
Okay. Yeah. What is the definition of compassion fatigue? Sorry if I may ask. Compassion
fatigue is exactly that. It's we see it in environments where there is an overload of opportunity or of pain and suffering, and there is a lower capacity to be able to either connect with that individual patient or relieve that suffering. So compassion fatigue happens. We're asking people to be present. And in fact, one of the things that we know is that compassion and empathy without the opportunity and ability to relieve suffering causes your pain center to fire. In imaging, compassion and empathy connected with the opportunity and ability to relieve that suffering, your pleasure center is what's actually fired. So which is fascinating, right? Because you think about, especially in emergency situations or trauma care, or that there is so much happening. When we don't make space and prioritize and give our care providers and our care teams the opportunity and also the tools to be able to make those connections and have an impact on how their care is provided, we're actually contributing to compassion fatigue and to burnout. And it's a real piece of burnout. And we've, worldwide have seen that escalate and just climb exponentially since COVID. A big piece of that is not having autonomy or not having agency on your work environment. So including physicians and care providers in the decision-making process about the programs that we're building, about our processes is critical. We do all this work thinking that we're just going to let them do their job and we're going to take care of the rest for them. No. Imagine if someone came in and said, you just go ahead and talk. I'm going to do this, this, and this that has a massive impact on your day-to-day and your ability to function and function at your highest capacity. So there are many different ways that that one needs to be able to incorporate and build, especially a patient experience process. One of the key things and key programs that I've implemented is helping the entire organization. In my last organization, I had developed a curriculum called Connecting to Purpose. It's not revolutionary. It's not brain surgery. It's literally making space. But we required it. We required attendance. So everybody from IT to marketing to food service to EVS, we taught some of the sessions in Spanish because our EVS teams were largely Spanish speaking. But it's a seminar about helping people, giving people the opportunity and helping them connect to their why. Why are you in healthcare? What does that mean to you? What's the purpose? And sharing our own whys. And those are always going to be patient-focused and patient-centered. Patient stories are the key to being able to help connect the clinical work with the human work and the IT work with the human work. It's not just test results and Petri dishes. I had a young resident say to me one day in a training, this is all great and nice, but if I'm practicing best practice, evidence-based medicine, why do I have to do all this other stuff? It should be enough that I know based on the values that I've gotten from the labs and the imaging that I've been, I'm equipped to make a clinical decision. That should be enough. And I said, and it would be enough if all you were interacting with was a Petri dish, but you're not. You're interacting with a human being. So if you are not able to connect with that person, that patient sitting on that exam table in that bed, all of your best practice in evidence-based medicine doesn't have the opportunity. You run the risk of it not connecting. So if they don't understand it, if they don't see you as someone who's there to care for them, if they don't feel at least seen and acknowledged and heard, then all of your medicine, all of your best practice, you're running the risk of it falling flat and not connecting. And then all of that is for naught. So you can't take the patient out of it. The patient has to be at the center of all of it.
How do you bring their stories to life? Is that like literally sharing the stories from the bed to the teams, or do you have developed methods to do that consistently, or is it happening anecdotally? Like, what does that look like in a day-to-day?
That's a great question. So one of the key ways to do that is sharing patient comments. So we have in our surveys, we have comment sections, and it's addictive. Once you've shared these positive comments, because the vast majority of solicited feedback is positive. Certainly the majority of the comments we get are positive. It's when we think about patient feedback in a negative way, we think about keyboard warriors who've gone to the internet to blast, their bad experience. And usually that's because they haven't had the opportunity to be seen or heard or connected with. So patient sharing comments is absolutely essential. And that is critical for any kind of broad engagement, actually small scale or large scale engagement, and investment in the experience. Using specific patient stories is absolutely critical as well. So just this past Friday, we had a health equity summit at one of our hospitals, and I was privileged enough to interview an employee who's also a patient with a chronic illness, and she told her story. And that story has been every single clinician and department lead that attended that summit has asked for a copy of that interview to share with their team members. It's about engaging that patient voice in any way possible. And sometimes it's interviews, sharing patient letters, sharing survey data, of course. I mean, the data is critical and we need it to mark our improvement and to be able to objectively measure our progress and our effectiveness. But it's the patient stories and comments that are critical. Yeah.
How do you work together with marketing and IT in that case? Because they obviously also want the stories, but you have to be really careful not to overpromise in many different ways. And sometimes it's about just building this or that capability into your systems, into your planning, into your resource system, whatever you are working on. But getting the right things prioritized that patients deeply care about, how do you get them to buy into that piece? Because if we look at their KPIs, you were even like hand gesturing, like signal silo to me, like for people listening on Spotify, like you're doing it like this. Like, how are you able to break out of these silos and let people look at it from the same perspective?
It's making that connection by highlighting the impact on the patient. So a patient story and that true human impact will break down. I'm being a little Pollyanna-ish, but that's the key to breaking down those silos, a common mission. And that connecting to purpose is a big piece of that as well. It's taking away and stepping outside those KPIs and making space for that connection and for that acknowledgement and understanding. But if you have the right mission in the organization, and if I'm incredibly lucky to be able to partner with two phenomenal professionals in our organization from marketing and IT, and their mission is in direct alignment with the values and the mission of the patient experience team. So I'm very spoiled right now, very spoiled. But it can be a challenge to patient experience and marketing. I certainly have lived that life where there's a little bit of a tug of war over who owns the data and who owns the feedback and and ultimately, when you put the patient at the center of it and you celebrate what you're able to have, the kind of impact you're able to have when you work together, it's really hard to ignore that, and it's really hard to continue down those silos. But also having someone in that chief experience officer role is helpful.
What do you think LifeBridge did differently so that you are, quote unquote, lucky to have such great partners in marketing and IT? Or are you lucky?
I don't think it's by accident. I really don't. LifeBridge also has people have been here. The longevity of the employees and leadership is remarkable, especially in a healthcare setting, and especially in an environment in a community where there's a lot of other options. So, I mean, we have Johns Hopkins right next door. We have, some very big players in healthcare. It's our mission. You don't come to LifeBridge, especially as an executive, if it's not meaningful to you to live a life. It sounds so trite, but of service in a sense. I mean, I'm not volunteering. That's, for sure. I definitely am in an executive role in a healthcare system. But it's really about the mission.
Joanne, thank you so much for joining me today. If people want to know more about the work you do, finding you, I mean, you mentioned seminars. I don't know if you give them publicly, but if they want to reach out, find you, what's the best place that they can do that?
Probably on LinkedIn. LinkedIn is probably the best place to find me publicly. Yeah.
All right. I'm going to put links in the show notes. Thank you so much for joining me today.
Thank you.
I wish the future will be true for you.
Thank you so much. It's been a pleasure. Thanks for your time.
All right, and that's it. Thank you so much for listening. If you found it valuable today, don't forget to subscribe to the Experience Edge on your favorite podcast channel, leave a review, and share it with your team. I'd be delighted. Today's episode was brought to you by Daydo, the AI journey management solution for enterprise. To have an edge on your business strategy and to know why your customers do what they do, visit daydo.com and explore more resources to accelerate your customer experience game. And remember, the journey to creating customer-centric impact never ends, and here's always a new edge to discover in doing things differently. Next week, new episode. Until then, keep pushing the edge, stay inspired. See you in the next episode.